Hey everyone. Thank you for being here today. This is Science Ask a Neurologist podcast series. I'm your host, Aarti Jain, and I'm a first-year medical student at New York Medical College. Today, I have the pleasure of interviewing Dr. Manisha Holmes, who is a neurologist at Westchester Medical Center. We're very excited to have her with us and to learn more about her career in neurology. So Dr. Holmes, thank you for being here today. How are you doing?
Great, thank you. Thanks for the invitation.
Yeah, and we're really happy to have you. I guess the first question that we'll start with is, can you tell us a little bit about yourself and your journey to becoming a physician?
Sure, yeah. So I was interested pretty early on in becoming a physician, but I think I initially, like as a kid, was interested in pediatrics, which I'm not really sure where that came from because actually neither of my parents are in medicine. I think it went from like wanting to be queen to wanting to be a pediatrician.
I love the career change.
A little different. And then in undergrad, I studied neuroscience, behavioral biology. And so that was really my first introduction to the neurosciences, and kind of picked that major early on because I liked neurosciences as well as it was kind of a combination of behavioral biology, basically. So it had anthropology, psychology, and neurosciences, which I enjoyed that combination. And then from there, decided, I wanted to do medical school, had more of an interest in neurology, but was also doing basic science research in the lab, mostly on genetics at that point and human stuff at that point. But then I did 2 years between undergrad and medical school at the National Institutes of Health, doing like a post-bac program where it was all research oriented and it was lab work. And I enjoyed that. It was a great experience. It gave me like bedside bench experience. And I liked it, but it kind of solidified that I wanted to be spending most of my time doing clinical work and not necessarily doing research. So I'm glad somebody's doing it. And I still like being involved kind of peripherally, but it made me kind of decide I didn't want to spend my time in a lab or even necessarily writing for grants and wanted to be more clinical. So then I went to medical school, tried to keep an open mind, but liked neurology. And then I was actually in Sign myself and was president of Sign for a year or two, I think. But I had an excellent neurology clerkship director who I'm still very close to, that really inspired me and got me even more interested in neurology. So I decided to apply for neurology residency, where then I came to New York and did my residency and fellowship at Columbia, and then decided to do epilepsy for my fellowship. And so I did a clinical neurophys and epilepsy fellowship, which I could talk more about if you want. And here we are. Fast forward a few more years after that.
That's so awesome. That's an amazing career path. When did you know for sure in medical school that you wanted to do neurology?
So like I said, I kind of always liked it, but I tried to keep an open mind. And I'd say I wasn't sure till I completed my clinicals. Because I wanted to kind of experience everything and see, and there were lots of things that I really enjoyed as a medical student. And I still look back and I think, it's such a fun time as a student because you get to do so many things broadly that you otherwise, wouldn't necessarily have access to. So like, I love transplant, but I didn't want to do transplant surgery, but it was a great rotation and a good experience. And, but it helped me kind of realize like, yeah, that was nothing I'd ever experienced before. And it was fun, but it wasn't something I wanted to continue to do as my career.
Gotcha. Were there any other specialties that like almost got you, that almost were able to take you away from neurology?
Probably the closest was medicine, but none were that close.
I love that. And you mentioned earlier that you like did a fellowship in epilepsy. Were you always interested in epilepsy or did that happen?
No, so that was much later. So neurology, what really drew me and solidified me to the neurology and that I think was the main difference with medicine even was, the neurological exam just tells us so much. And there's very few specialties that the exam helps you that much. And so it's adds to your detective work, and you have more tools. And I just think, thinking through the localization and your differential is just so interesting. And so I went into neurology liking everything. And back then, I think we had to apply at the beginning of our PGY3 year or something, maybe even the end of our second year. You've really only done, at that point, we had really only done mostly inpatient rotations and hadn't gotten that much exposure to outpatient. Luckily, a lot of that is changing now, and we're getting more and more subspecialty exposure early on, and they've pushed back a lot of the fellowship application. But I liked everything, so I was really not sure. But in the end, I wanted kind of a chronic relationship, but I liked acuity and I liked outpatient. And this allowed me to do everything in a way, because I like critical care EEG. So it keeps me in the ICU. It keeps that acuity, treating status, non-convulsive status. But I get that long-term relationship with patients. And I think what really set it apart for me was, majority of epilepsy patients actually get better. So 70% of patients will respond to one of the first two medications they try, and you've made a huge impact on their quality of life. So they can go back to doing all the things that they love to be doing a lot of the time. And for, that unfortunately other 30% that are refractory, I think our therapies are getting much better, and epilepsy is a really exciting field to be in right now with all these new neuromodulatory devices, new medications with less side effects. And it's just a rapidly changing field, I think, with a lot of options and less progressive, declining kind of areas.
That's awesome. I actually didn't know that a lot of epilepsy patients end up, getting back to where they were before. That's awesome.
Yeah. And even with epilepsy surgery, I think a lot of people think, oh, that's so scary, brain surgery, but the goal of surgery is to localize where the seizures are coming from and remove it if it's not eloquent cortex. And so, the goal is seizure freedom with no deficits. And that's what majority of patients who end up getting a resection have no deficits. Now, how well they do kind of depends on the type of epilepsy and where they are, but it can be a really great treatment for anyone who's refractory with focal epilepsy.
That's so interesting. And do you work with kids with epilepsy or just adults?
So I'm trained as an adult epileptologist. So sometimes in fellowship, there's some overlap. And even as an attending, sometimes you can cover peds. So you are certified to be able to cover, but you're not a pediatric epileptologist. So usually, the pediatric neurologists do a peds epilepsy and adult epilepsy, but you can kind of cross cover when you need to.
Gotcha. And how would you describe your typical work day, when you get into the hospital to when you clock out?
Yeah. So, I think in general, there can be a lot of variation with epilepsy, which is really nice. And one of the reasons I was also interested in it, you have a lot of flexibility depending on what sort of position you choose on how much time you're going to spend reading EEGs versus seeing patients, and whether that's inpatient or outpatient. So mine has been mostly stable over time because I've stayed in academics and at major referral centers. But I think as a whole, my day is not necessarily what someone in epilepsy's day has to be. But I like my day. So currently here, so I started here basically last fall as Section Chief of Epilepsy, and we're really trying to grow the epilepsy division here on the adult side, which has been really exciting. But we have a couple main things, which is that there's the acute EEG in the hospital that you see, inpatients on that came in through the ER and either need to have seizures ruled out, or we know they have seizures and we're trying to get them under better control. And then there's the adult epilepsy monitoring unit, where we electively bring in patients to capture their seizures for pre-surgical evaluation or characterization or for rapid med adjustment. And then there's outpatient EEGs where patients are being referred for an EEG, but they don't necessarily need to come into the hospital because we're not removing medications. And then there's outpatient clinic. So for me, I do a variety of those things. So the average day might be reading EEGs in the morning. I take my daughter to school and then I come in. So sometimes I start early so that I can get those EEGs read in order to take her to school. And then I come in and we'll finish up like reports, round on whoever needs to be seen, and usually have some meetings. And then in the afternoons, I'm either in clinic or reading outpatient EEGs. And then more meetings.
I love that. There's a lot going on.
Yeah. And you know, one of the things I really like about academics is also teaching. And, you know, I do like being involved in research, kind of more collaborative research. So like multi-center stuff or somewhat like clinical trials and those kind of things. So I'm involved in a lot of those things. And so that's what some of those meetings are in addition to administrative stuff.
Yeah. And kind of just going off of that, like how would you describe the work-life balance that comes with being like a neurologist who does like epilepsy specifically?
Yeah, so I think you know, again, it depends what you do. I think it gives you a lot of flexibility and the opportunity to have a better work-life balance because you can you know, be a little bit flexible with when those EEGs are read, in that, you know, if they're acute EEGs, you can't put them off for hours or days, but you can, you know, say you're going to read them earlier in the morning or later in the morning. And then, you know, depending on where you are, there may also be fellows that help read or techs that help read. And so, you know, some places there's remote reading options. Even here on the weekends, we read remotely. So even if I'm on for the weekend, I'm home. So I, you know, have my daughter around, which is nice. Well, it can be nice that she's getting pretty good at reading seizures. So, you know,
Okay.
but the really obvious ones she gets.
A little assistant.
Yeah.
And like, how often are you on call? Like, is it like are you the only, you know, epileptologist in the hospital, or are you guys like switching?
Yeah, so right now we have a pretty small program here. So it's myself and Dr. Ramani. So one of us is on at all times, and he, to his credit, does most of it. So I don't know how he does it, but he does most of the calls. So I'm very lucky with that. I do about 1 week a month and 1 weekend per month. We each do about a weekend per month, but he does a few more nights than I do right now. But it just depends on the place. You know, other places that are larger, you know, your call pool is bigger, or if they're, you know, in the past where there were fellows, and so fellows took, you know, kind of first line calls, and then they'd bump it up to you if there were questions.
Okay. Yeah. So it's like kind of hospital to hospital type thing in terms of, okay.
Yeah. And, you know, some hospitals don't have 24/7 coverage for EEG. And so they may have no one reading at night.
Okay.
And if you're not in a place that's doing, you know, critical care or acute EEG, you may not need that. And then if you're doing strictly outpatient, then you wouldn't have that.
Okay.
You may get patient phone calls still, so it just depends, like with anything, who's covering those patient phone calls and who's on at night.
Right.
Here, that's in a different pool.
Okay.
With all the neurologists as opposed to just the epilepsy patients.
Gotcha. All right, so I'm gonna like switch gears a little bit towards like more general questions, just regarding like neurology and kind of just having a career in neurology. So what would you say are some of the biggest challenges facing neurologists today?
I think it's probably pretty common in that a lot of the same things that, you know, everyone in medicine is facing right now. Some of that is starting to change for the better, but I think it's, you know, the time issue of how much time documentation takes, calling patients back, and kind of spending the time the way you want to spend it, as opposed to a lot of the other things that, you know, you kind of have to do as part of it. And, you know, reimbursement for that can sometimes be a problem because that's what kind of prevents you from, like if you really like to teach, that's not something that gets billed. So then it's like pulling you out of clinic. And so I think that finding ways to be able to do the things that we all really like to do, like spending time with patients and teaching and research, but having it, be in a way that works for whoever's employing you is hard.
Yeah, I can definitely see that, especially with like so many, changes happening all the time, like anything. Yeah.
But I think people are aware of that problem and things are coming around. We'll see. My husband I've only read the abstract. I have not read the article yet, but he just sent me, he is an internist, but he just sent me a JAMA article about how ChatGPT is empathetically and appropriately responding to patient questions better than providers. So, we'll see what happens.
Yeah. Maybe it'll, encourage people to be more empathetic, And like kind of going off of that, how would you say, or like, how do you think the field might change over the next few years? Whether it be research or, more like in the hospital?
Yeah. I think some of it is already happening, of the dividing hospital time from outpatient time. And, there's more and more kind of neurohospitalists and PAs to help kind of divide that workload up. But I also just think, in general, kind of like I was saying with epilepsy, the therapeutics for neurology are just getting so much better. And there's just so many exciting things coming through the pipeline that it's just, that's one of the reasons I don't do general, is because it's so hard to keep up, because there's so much exciting stuff coming through. But you're like, well, we don't do that anymore. What do we do now? And I know it's like that for epilepsy. I know to people who are not that familiar with epilepsy are like, surprised at the devices we're using, or some of the newest medications they've never even heard of at this point. So it's fun. But yeah, I think there will be lots of changes. And obviously AI, I think for everyone, who knows where that's going to take us.
Are there any like devices or medications that are about to come out that you're really excited about, or like, research that you think is like super cool?
Yeah, so this past week was actually the American Academy of Neurology annual meeting. And so there was lots of stuff there. And one of the sessions I was in was an epilepsy session, but there's always just, new medications with hopefully better outcomes, because, like I was saying before, that 30% of patients who don't respond to medications, they tend, once they've failed 2 medications at adequate doses, unfortunately right now, there is really no other medication that we can say is better than the other. But there's a couple now, one being out that we may need more long-term data on, and a couple being investigated that maybe have better outcomes in patients who have been otherwise medically refractory. So that's always exciting. And then the devices that we do have for epilepsy, we're learning more and more about, in terms of how we can improve the therapy being delivered by those. So, and one really great one that's come out, like, I guess, in the last 10, 12 years, is the responsive neurostimulator. But that's just a great example of something that's come out in the last 10 years, and what we're still learning from it, but it's implanted into the brain, where you put electrodes in the areas where you think the seizures are coming from. And then it has a generator, and it actually records seizures by detecting certain patterns that it thinks is concerning for seizures, which the provider can optimize over time. And then it delivers stimulation when it detects that, to try and abort the seizure, but over kind of like an AICD would for the heart. But over time, it's called neuromodulation. It changes the circuitry of the brain and reduces seizures. But it's great in that you get these chronic recordings and all this data to work with over time. And, who would have thought that you could have something that's recording like that? And so I think there'll be more and more stuff like that comes out, and treatments that are kind of more personalized and more seizure specific over time. Then also all the, genetic stuff, and figuring out why some medications work for some people but not for others, and how can we optimize that.
That's super cool.
Another area I've been involved with is microbiome, which is also super interesting that we're learning more about these days too in many fields, but epilepsy is one of them as well.
That's awesome. Yeah, that device seems like amazing that it can do all of that and like give you all the information and, make those changes.
Wow. And I think a lot of people think you can't put stuff in your brain, but you can put a lot of stuff in your brain just fine.
Just the right stuff.
Right places. You got to put in the right places, the right stuff.
That's awesome. And as I get to kind of the last few questions that I have, do you have any advice for any aspiring neurologists that are interested in the career or, potentially going into it?
Yeah. I mean, obviously I'm biased. I think neurology is great, but all my friends who have went into neurology, I don't think anybody dislikes it now. Everyone's loved it. And I think one thing you don't necessarily think about when you're picking a specialty, and this is definitely on my mind, like I said, after coming back from this meeting, which was a more general meeting. So, we saw a lot of people that are outside of epilepsy, and neurologists are just a really nice group of people. They're very friendly, they're very nice, they're all doing very exciting things, but it's just a very friendly, nice group to be part of. So it's just kind of an added bonus that you don't really think about. It isn't necessarily a reason to pick a career, but it's a nice bonus. So I think, my advice would be you want to pick something where you're passionate about the field. It excites you to be there. You're excited to hear what comes down the pipeline in the future, because it's going to be a long time that you're doing this. So you want to really enjoy it and you want to feel comfortable. And so I think, when you're on rotations and you're like, I really like this group, you should listen to that because there's probably a reason.
I love that. That's awesome. And yeah, my last question for this interview is, what would you say is your favorite part of the brain, or like the CNS, and why?
I guess I'm, probably biased, but I gotta, and I mean, there's a lot of good stuff coming in for, the basal ganglia and the brainstem these days, but the cortical stuff is my favorite because it's just so interesting that, all these different things can be so localized. So, one of the things that I really enjoyed as a resident, and I think I got to see as a medical student, which, if you guys are interested in on electives, definitely let us know. But there are a couple tests that I saw early on in epilepsy that I really found interesting. One was a WADA test, which is a test where, if we're considering epilepsy surgery, we want to know, if we took that side, not the entire side, but part of the side of the brain out, what would the other side be capable of doing on its own? And so we do that when we're worried mainly about language and memory. And so the WADA test basically is an interventional procedure where they go in through the groin up to the carotid and inject like Amytal or Brevitol, which basically anesthetize one side of the brain while the patient gets neuropsychological testing for their language and memory. And so you can see transiently what the other side could do without the other one working, and say, okay, the other side is compensating well enough, the language is on the other side, their memory is great on that side. And a lot of times we'll find that the side the seizures are coming from, their memory may be poor there anyways because of the seizures, and so they kind of wouldn't miss it if it was gone is what we're trying to figure out. So that was really cool. And then we also do something called cortical mapping, where, if we're worried that the area the seizures are coming from may be involved in language or motor, then while those intracranial electrodes are in, which we place kind of to give us a high definition picture of the areas we're really interested in based on our pre-surgical workup, then we can deliver electrical stimulation to 2 contacts at a time and ask the patient to do certain functions that we think, that area of the brain would be responsible for. So if it's language, we give them language tasks. And as you stimulate the brain at the bedside, it can interrupt their language. And you can tell that that area right under those electrodes is what's responsible for their language or their motor. And so that we should not take that area out. But I think that kind of stuff is very cool.
Yeah, that's actually so awesome. I would love to see that if I could ever do that in rotation.
So localization, I would say, is very cool in stroke too, but it's not as happy. Epilepsy, it's usually more transient.
Yeah. That's awesome. Yeah, I've honestly talking to you today was has been so eye-opening about just epilepsy and being a neurologist. So I'm really happy that you were able to spend your time with us today.
Well, thank you. And like I said, welcome anyone to come join us at any time if they're interested.
Yeah, definitely. I will definitely encourage everyone that I know because it sounds so cool.
Great.
Thank you so much, Dr. Holmes. Have a great rest of your day. And thank you for joining us for our podcast.
You're welcome. Thank you.